Hi, Mitney. I'm doing great. Thank you for joining me. Thank you, Caitlin. Yes, especially for a Friday, right? I am early. I try to be on time. It's just sometimes I think I have all this time and then I don't. And I'm like, where did the time go? And I recently stopped wearing my watch, my wristwatch. I need to go get it fixed because I think it's, hi Ashley, I think it's running slow because I'll set it to the correct time and then it'll just, like I'm running late because I'm looking at my watch thinking I have time and it's just running slow. So I don't know if there's something wrong with the mechanism. That watch is almost 20 years old. Well, it is 20 years old now. So yeah, I've had that watch forever. So think I need to go get it fixed. Hi Christina. Hi Ashley. Thank you so much. I was told I look like a blue ball of sunshine today because of the yellow, which was nice because it was very rainy here today, all day today. Hi Hannah. Thank you for joining me. So yeah, and hi Guy. Yes, I'm early. I have to keep you guys on your toes, right? I have to show up early, do things a little out of the ordinary to keep y'all. uh, hello, Aaron. Nice to see you. All right. Yes, it is good to start on time. I'm always proud of myself when I do that. Tonight we are going to be talking about sequencing, and we are going to be going over some really good articles that when I update the list, update the description box, I will be leaving those links in the description box so that way you guys can check them out. And please do, because these are very good and well-written articles. I approve. They are Bleu approved. So, hi, La Morgan. It's nice to see you too. That way you guys can get more familiar and see where you can start learning other things about coding from other sources. And these are really good sources. I like the way they phrase it, the very straightforward way they phrase things in these articles. I like those too. So since it's already 7:31 and we have a full house already, so let's go ahead and get started. If you are brand new to my channel, welcome. I am Blue. I'm a medical coder. I am trying to do study hall, right? At least once per week on a Thursday, mostly a Thursday. I did it today because yesterday was just a different conversation that I wanted to have. And a lot of my shows are inspired by you guys anyway. So that is something that I wanted to go ahead and talk through and talk about. But today, being that we haven't talked about coding in a minute, let's go ahead and talk about sequencing. I get asked this question all the time. Blue, how do you know how to sequence the codes? I used to ask this question when I first started as a medical coder because I was like, how do you know which ones to put first? And then after a while, you start to learn. So if you're in the same boat, trust me. Yeah, I've been there, done that. Got a t-shirt too. And guys, telling everybody that he is not a ballerina. Gotcha. Hello, King. Good to see you too. So, getting into this, I'm going to talk about my pointers for sequencing, and then I'm going to read three very good articles, read from there. Three very good articles. Again, I'm going to be leaving those in the description box, so that way if you guys want to look at it later, you totally can. When it comes to sequencing, you have to first find out why is the patient showing up. Why is a patient even there? And if they have multiple conditions, sometimes a patient will come in with an injury, and let's just say they broke their arm, and they also have diabetes, and they also have hyperlipidemia. So you have two other conditions in addition to this injury. Well, the hyperlipidemia, it can be serious, but most of the time it is controlled with whatever they're controlling it with. However, the diabetes can play a big part in it if the doctor has to decide to give them a shot for pain relief. They have to make sure that they're not giving them steroids, because if their blood sugar is not checked, it could be through the roof, because that's what steroids do to diabetics. So they always have to make sure that they check their blood sugar before they go and they give them any kind of medications. They have to consider that. So while diabetes is very serious, that is not going to be the very first listed diagnosis. It is going to be what brought the patient in, which was the injury. So if they have this broken arm, they come in with pain, right? Because they don't know it's broken until the doctor gets them under the x-ray and says, oh yeah, it is broken. So in the outpatient setting, we don't code the symptoms. Now, in sequela, that is going to be something different, and you have your manifestations, but that is separate. Right now, we are talking about injuries. When you have a definitive diagnosis, like they came in with arm pain, and it turns out their arm is fractured. Okay, now we take away that pain code because we don't need that right now. We're looking at an injury. So we're going to code this injury with active or subsequent, depending on what is actually happening for this patient. But let's just go that it's an active treatment, okay? We're not going to sequence anything else first except for that injury, because that is why they are there visiting the doctor. Then you have the two other diagnoses, which is the diabetes and the hyperlipidemia. So of these two, the doctor really has to consider the diabetes first, because cholesterol is one other thing, right? But that diabetes, again, he has to make sure that this patient's blood sugar is not all over the place. And even if the blood sugar is okay, the patient is also at increased risk now, because they could get sores, right? Because they're diabetic, and the skin is extra sensitive. So that is something else that you have to think about. So when you're ranking the diagnoses, you're not going to rank that hyperlipidemia next. It's going to be that diabetes, then the hyperlipidemia, then the external cause code. So the external cause code, and hopefully your providers document these external cause codes, because yes, there is not a national standard for documenting those external cause codes. I wish there were. It does not mean that you can't ask for more of your providers, because we never know. Things change all the time in coding. So because they do, get your providers used to writing down the external cause. How did this patient get injured? And it's not just on the very first visit, it is on their subsequent visits as well, because it's always good to have that external cause code along with that injury code. And that is what I ask of my providers, and they do it. So even on the subsequent visits, they do tell me this patient has a wrist fracture because they fell and slipped and fell on some ice. Boom, I have my external cause and I have my injury code. So injury code is sequenced first, then your diabetes in this situation, your diabetes, hyperlipidemia, and your external cause code. The external cause codes and your status codes, like if they had an organ removed and it's pertinent to this encounter, you're going to sequence those last, because those are more informational rather than going to really impact what's going on currently in the encounter. Yes, some status codes can impact what is going on in the encounter, like if they are taking long-term use anticoagulants, that could play a part in it, but it's not going to be up there in ranking, because that Z code for those long-term use codes is going to be anchored at the bottom. So that is when you're thinking of, okay, how important are these diagnoses in relation to why they came in? If you have a patient who has multiple injuries, you're going to look at the injury that is the most critical, or the most one that is taken care of the most, right? If they have a laceration on their arm and then they have a contusion or a bruise on their knee, and the laceration on their arm is going to take a lot more of the provider's attention, because they have to clean it out, they have to clean it up and make sure everything's okay, if they have to do any kind of suturing and things like that. So that is more involved than a bruise on the knee. So that is how you'd be like, okay, so laceration first, then bruise, or whatever is taking most of that provider's attention. So that's how you can rank those. And that's always what you're going to think about first, is what brought this patient in and what is the most critical, what is the most serious. Now, if you have two diagnoses that are equally as serious, then you need to consider which one is taking more resources that you can see on this chart, right? If they're equal, then you can pick one or the other. But if you are coding on the inpatient side, you know, you have to consider these things, even on the outpatient side, but you still have to consider which one is taking the most resources first. And if you don't know, again, start asking questions, start doing your research, and look in your specialty. There's lots of specialty websites for all the specialties. For orthopedics is orthoinfo.org. There you can learn a lot about the procedures, you can learn a lot about injuries and the organic conditions. So it's not just them. They have also other websites for the American Academy of Family Practice. I think that's the way it is. I'm not sure. But they have a lot of really good articles there too as well. So if you work in family practice, that is a really good resource to look into. Because it's going to tell you all kinds of good things about coding. It's going to tell you all kinds of things about how their visits are set up. So make sure that you're doing your research, even for cardio, even for pulmonary. There's one for every single one. So that's how you can get to learn what is most important and what is most critical. Don't spin your wheels thinking about it too much, because as long as you're getting those, you're hitting the main ones first. And then all the other ones you can start to think about later. But you want to make sure that you're getting those main diagnoses listed correctly first. So think about what caused that patient to come in and what is taking the most of the provider's attention. And that's how you can go from there. So let's see. The articles that I have. And I like all of these. This one actually came from the AAPC website. So when I pull it up, I like this article because of the way that it's written and the lady who wrote it, her name. Her name is Norma Panther. That is an awesome name, not only because her name is Norma, but her last name is Panther. So this is her article in which she wrote, Sequence ICD-10-CM codes for proper payment. 5 terms lead the way in determining primary diagnosis codes. When we select codes for billing, we are telling the story of a patient's healthcare encounter. Patients often present with multiple conditions, some related, some not. Medical coders are tasked with selecting the most specific codes and putting them in the right order. This code arrangement is called sequencing, and it is the essential step to correct coding. This article focuses on identifying what you need to report additional diagnoses and determining their proper order. If you are unsure of what to look for as you're trying to determine the right codes and sequencing, follow the terms referenced in the ICD-10-CM guidelines for coding and reporting, right? So, in diseases classified elsewhere, first things first, why is this patient being seen? The reason for the visit drives the code sequencing. This is generally the first listed diagnosis. Since the first listed diagnosis is established, it may be followed by other coexisting conditions. Sometimes the first listed diagnosis will be pointed out by conventions or code first notes. So when you're looking in your in the tabular section of your ICD-10-CM book, there's lots of notes that say code first or use additional code. So these are kind of giving you those tips about the sequencing as well. So if it's telling you to code first, it's literally telling you that other code is going to go before this code that you're looking at, right? The one that has a code first. So that's how you're going to be able to get those. If you see a use additional code, that means that use additional code can be sequenced after this code that you're looking at. So it's going to give you these little hints in which way to go, right? So again, all of your status codes are going to go towards the end, and your diagnoses that are either driving the visit or affecting the patient and the visit are going to go in that order. And it says, in diseases classified elsewhere, reference the official guidelines at IA 13. The convention instructs you to code in diseases classified elsewhere, codes second to the etiologic condition. Etiologic conditions are usually listed under the code. Example 1, primary stomach cancer of the fundus with dermatomyositis. I did it. So the first listed would be the primary malignant neoplasm of the fundus of the stomach. When you look up this code in the tabular list of the ICD-10 CM book, you'll find in this category the instructional note, use an additional code to identify alcohol abuse and dependence. And then M36.0, dermatopoliomyositis in neoplastic disease. When you look up this code in the tabular list, you'll find the instructional note that says code first the underlying neoplasm, and then it'll give you the C00 to D49. So that is another way to know if you're putting them in the correct order, right? Because you would never flip them, right? And then the second example is Parkinson's disease with dementia without behavioral disturbance. So you would code the Parkinson's disease first, and then you would code the F code, F02.80, dementia or other diseases classified elsewhere without behavioral disturbance. When you look this code up in the tabular, you'll find the instructional note, code first the underlying physiologic condition. And then sequela, my favorite, late effects. A sequela condition is one that results from a previous disease or injury. Coding for late effect usually requires 2 codes. Sequencing comes directly from the official guidelines at 1.B.10. I think I said I in the other, sorry. Example is a keloid scar as a late effect of a 3rd degree burn on the chest wall. So in that instance, you're going to code the scar first, or the hypertrophic scar, L91.0, followed by the injury code, which is the burn of 3rd degree of the chest wall sequela, which is T21.31XS for sequela. So that's how you know. Any of those things like that. Okay. Use additional code. This convention instructs you to code first the underlying condition, followed by the etiology and or manifestations. It appears in the guidelines. The use additional code note is found below the underlying condition code. For example, type 2 diabetes with stage 3 chronic kidney disease. E11.22, type 2 diabetes mellitus with diabetic chronic kidney disease. When you look up this code in the tabular list, you'll find the instructional note, use additional code note to identify the stage of the chronic kidney disease, N18.1 to N18.6. And then because they said that it was, they didn't say, yeah, they did. They said it was stage 3 chronic kidney disease. It would be N18.3, chronic kidney disease, stage 3, moderate. When you look up this code in the tabular list, you'll find the instructional note, use additional code note to identify kidney transplant status, Z94.0, if applicable. So if this patient has had a kidney transplant, then you would add that additional code. Because again, that's how they're getting the sequencing. Code also. This convention instructs the 2 codes that 2 codes may be required, but it does not provide sequencing direction. It appears in the guidelines. The circumstances of the encounter will determine the sequencing. Example 1 is secondary pulmonary arterial hypertension in HIV. The reason for the encounter is HIV, right? Because it's literally saying secondary pulmonary arterial hypertension in HIV. So the first listed code in this situation is B20 for the HIV, and then I-27.21 secondary pulmonary arterial hypertension code, also code, right? When you look up this code in the tabular list, you'll find the instructional note for code also, associated conditions, if applicable, or adverse effects of drugs or toxins. And then the other one, example, Conn's syndrome with right adrenal adenoma. So the D35.01, benign neoplasm of the right adrenal gland, code, also code. When you look up this code in the tabular list, you will find the instructional note to use additional code to identify any functional activity, as this determines the order. And then you have the E26.01 for Conn's syndrome. When you look this up in the tabular list, you'll find the instructional note that says code also adrenal adenoma, and that's a D35.0. Brackets, those brackets, different from the parentheses, so it's the brackets. These, this type of punctuation appears in both the alphabetic index and the tabular list. It appears in the official coding guidelines. Codes that are in brackets in the alphabetic index are always sequenced second. Brackets are used in the tabular list to enclose synonyms, alternative words, or explanatory phrases. Example, xanthanoma, whatever, epidemic with meningitis, and then alphabetic entry A88.0, and then the brackets is G02. So it's giving you the enteroviral xanthamus fever, Boston xanthan, and then G02 is a meningitis and other infectious and parasitic diseases classified elsewhere. It's very important that you guys learn what the punctuation is and what it means. So that way you can see that if you saw something like that instantly, you'd know that that is the sequence. Coding tip: remember to follow the ICD-10-CM coding guidelines and reporting for the current year as you encounter different coding scenarios, and that the conventions of classification take precedence over the guidelines. The guidelines are based on the coding and sequencing instructions in the ICD-10-CM codebook. So thank you, Mrs. Panther. That was a very good article, and I like that. And not just because of her name, but it was because it's well written. So I saw some comments coming in. Let's check those. Okay, so I must have seen it. Hi, Edel. All right, so let's check the other article that I had pulled up. Does anybody have any questions about sequencing so far? Okay, I don't know why I put that one. I'm going to go to Kim's article. So this lady, Kim, I like her. I believe I met her at conference because she looks familiar and they have a picture of her face. So I believe I did meet her. She's with Health Information Associates. She wrote a very good article called Coding Tip, Code First, Instructional Notes in ICD-10-CM. This article was published in June of 2019. Kim Carrier is an RHIT, CDIP, CCS, and CCSP. She is an AHIMA approved ICD-10-CM and PCS trainer. What does code first mean? There are certain conditions that have instructional notes in ICD-10-CM tabular and coding conventions that guide the coder in sequencing. This is especially true when the condition has common manifestations or underlying conditions of a chronic disease. If there is a code first note in the tabular, the coder should follow this instruction and sequence the underlying etiology or chronic condition first, followed by the manifestation as an additional diagnosis. There would be a use additional code note at the etiology and underlying condition. So this is why I tell you guys to get familiar with your book, like to literally open up the book, go through all the pages, especially in the tabular section, look at those notes that say use additional code or code first or see also code or whatever. You want to be able to look at those because then that's going to get you more familiar. You're going to get a better understanding of what's happening because there's a lot to go over, folks. There is so much to go over in that book. So you want to make sure that you're taking the time to look at all of those notes while you can. Most common examples of incorrect sequencing. The patient presents for drainage of pleural effusion that is documented to be malignant secondary to lung cancer. The patient has thoracentesis and is discharged home. In this case, the primary diagnosis first listed code would be the lung cancer followed by the code for the malignant pleural effusion. In the ICD-10-CM tabular, the coder will see notes under the category J91.0 to code first the underlying neoplasm. Coders will see the same code first instruction when looking at malignant ascites. And then patient presents with anemia and is admitted for transfusion. The anemia is documented to be due to end-stage renal disease, ESRD, after workup and consultation with hematology. The patient is discharged to follow up and continue their outpatient hemodialysis. In this case, the primary first listed diagnosis code will be the ESRD and not the anemia. Even though the anemia is the condition that was treated and focused on the admission, there are instructional notes in the ICD-10-CM tabular instructing the coder to code first the underlying chronic kidney disease. So that's why I'm telling you guys, make sure when you're looking up these codes that you are looking for those notes, those additional code first or use an additional code notes. The other example is a patient is admitted with acute on chronic systolic congestive heart failure and the diagnosis of hypertension. ICD-10-CM assumes a causal relationship, and this is coded as hypertensive heart disease with CHF and an additional code for the specific type of heart failure. In this case, the primary diagnosis of hypertensive heart disease with CHF I11.0 is reported as a primary diagnosis, followed by the code for the heart failure I50.9. Under the category I50 in the ICD-10-CM tabular, there are instructional notes for the coder to code first if due to hypertension. There are multiple code first instructions in this under this category. The next example is, see how complex this can get? The next one is a patient presents with confusion, altered mental status that is more than the normal for them. There is a history of Parkinson's disease with dementia. Workup revealed that the patient's Parkinson's disease is progressing quickly and their medications were altered. The patient was observed with a one-to-one sitter without much improvement. It is recommended that the patient be admitted to a nursing home that focuses on dementia patients. In this case, the diagnosis code for the Parkinson's disease, dementia with Lewy bodies, is reported as a primary diagnosis, followed by the code for dementia in diseases classified elsewhere as a secondary diagnosis. As an additional secondary diagnosis. The patient presents with chest pain and has cardiac catheterization during their hospitalization. The cardiac catheterizations, tongue twister, showed that the patient had multi-vessel coronary atherosclerosis of the native vessels with occlusion in one, as well as atherosclerosis due to calcified coronary and lipid-rich plaque. In this case, the code for the atherosclerotic, there we go, heart disease of the native coronary artery is sequenced as a primary diagnosis. The calcified coronary and lipid-rich plaque atherosclerosis would be reported as a secondary diagnosis due to the code first instructional note in ICD-10-CM. Coders should always review and follow the chapter-specific guidance in the ICD-10-CM tabular when coding to ensure that the appropriate primary diagnosis is selected. It's not always black and white when the focus of the admissions is towards the manifestation and not the condition causing it. This sequencing advice should only be followed when there is a coding guideline or instructional notes in ICD-10-CM. It will not always be the underlying condition reported as a primary diagnosis. The best examples of this that I can think of is anemia due to acute gastrointestinal bleeding and acute respiratory failure due to pneumonia/COPD exacerbation. In these cases, the primary diagnosis will depend on the focus of the admission, as there is no code first instructional notes to follow. So she lists all the references and she says, happy coding, Kim. So happy. I like that. All right, here we go. Christina, I like the code sets with the guidelines. Do sequencing rules change every year? No. There's some updates to some things, but it's not like how the guidelines get updated quite frequently every year, right? They get updated. And there's new things that are added, there's things that are taken away. With sequencing, most of it is pretty much done. There may be updates, but those rules are there, you know. Hi, John Daniel. I'm doing great. Hi, Aurora. It's good to see you. John Daniel, I'm always surprised on how many coders don't think those codes properly in relation to the assumed causal relationship, unless specified differently by the provider. G30. Amy says, will we be able to view this presentation again later? Yes, you can watch the playback at any time. John Daniel, my brain is fried from work today, and I totally worn out and ready to listen and chill and eat my KFC famous bowl, the large mac and cheese. Oh, speaking to my heart, I love the mac and cheese from KFC. Teach on, Blue. Clap, clap. Caitlin says, yeah, I'm here to listen. I'm currently battling with having a household member with COVID. Oh my goodness. And thank God I'm negative, but I start a new job in 3 days and have my exam. Yes, isolate for sure. And I hope that they get better very soon. Amy says, awesome. Thank you. Appreciate you sharing your knowledge. Of course. I'm happy to do it. So a lot of what we do is interpret what we see in this documentation. You know, it's going to be different every single time, because there are some times when you're seeing a patient and they sound similar to another patient, but of course that other patient's being treated for something else different. Or the way that you think of, it's not always going to be that same scenario every single time for patients in that particular situation, right? I'm talking about like COPD patients, or, you know, patients who have hypertension and chronic kidney disease. So there's always going to be something. What we do is interpret. That's what we do. And a lot of times when you have coders that are seeing different things from one provider's documentation, is because that provider needs education. And there is always that. If there's an issue, it's usually that's because the education is lacking. So when you have something like that, you know, it's important to sit and talk with your providers, because then you know, okay, what else is going on here. If you have a patient who is coming in for like post-op care, and all of a sudden they're being seen for something else different, you know, you have to think of how those things are going to be sequenced. Was the reason for the visit for the post-op, or was the reason for the visit the reason that they came in for something new? And then, oh yeah, by the way, we're in the post-op. So you have to look at those things, and it should be clear in the documentation as well, because when you're thinking about how are you going to sequence this, how is this going to go, you're going to look at those things. And when I look at a patient who's coming in for something additional in the post-op period, when it's typically the visit's already covered because it's under the global period, if it is unrelated and they're seeing them for something new, okay, then that's going to be your first listed diagnosis. And then whatever's going on with them for that, and then you're going to have your aftercare, whether it is the aftercare for the orthopedic or cardio or gastro or whatever they're coming in with, you're going to have that listed towards the end, because if that's not the primary focus of the visit, then what is? So I always say to make sure when you're looking at this documentation, just make sure that you're being thoughtful about how you're sequencing these diagnoses. So I just saw a bunch of stuff come in. All right. John Daniel, hey Blue, I think ICD-11 is going to be good. I hope they add codes that should be added years ago. They should have a lot more bilateral codes, I think. They do for carpal tunnel, G5603, yes, but not for commonly used codes like knee pain or shoulder pain. Yes, that is true. But there is a bilateral osteoarthritis of the knee code, but there's not a bilateral shoulder osteoarthritis code. But there's a bilateral hip. So I don't know what they were thinking on some of those, but whatever. Caitlin, there's not a bilateral code for carpal tunnel. There is. G5603 is the bilateral code for carpal tunnel. They also have a bilateral code for cubital tunnel as well. So because you commonly use one for right and two for left. That's right. You know, but you would think that there would be bilateral, because most of the time, you know, that sounds, it sounds too situational. Yes. So depending on what the condition is, sometimes there's a bilateral code and sometimes there's a single code for each side, you know, because sometimes I guess it all depends. If they have a bilateral knee joint replacement, I know there's the one code for that. Instead of just using the right and the left, if they've had both joints replaced, then you would use the bilateral code, right? Which almost always ends in a 3. So yeah, those are the bilateral or the single side codes. So yeah. Heck yeah, Z. That's right. Yeah, that does throw me off a little. But yeah, I know that's the that's the close one. Yes, but I can't be sure if that was the knee or the hip though. I think that's the hip. Z96.653 off the top of the dome. Let's see. I have my book right here. Let me look it up. Because I can't think it off the top of my head. I know what the osteoarthritis is, if you ask me that, and you would think I would know, right? As many times as I do it. 653 would be, is it 653? Yeah, 653. Yep, it's the knee. Yep, it is the knee. The presence of artificial knee joint bilateral. And like I said, getting familiar with the different sections of your book is going to help you, because then at least you'll know, especially if you're visiting all those Z codes. And the Z code section is not that bad. It's not that big, but at least it'll kind of give you an idea. because it does also have that encounter for codes. There's going to be times when a patient is coming in for their annual physical, right? And they have a code for encounter for annual physical, right? And then with findings, without findings. So if you're not accustomed to selecting a code like that, you may miss it. Or if they're coming in for chemotherapy, if they're coming in for what is it, like a pre-procedural, right, exam before they go in for surgery, the Z01818. See, that one I know. But that way you can get familiar with those, because you'll see sometimes these doctors will say, oh, the patient is here for a pre-op exam, and then they will talk about what they're going to go in for surgery for. So that's how you know to sequence those that way. There's also a section in the ICD-10-CM book of first listed codes only, right? Let me see if I can find that in here while I'm here with you guys. That's why I love Optum. I guess what's new for 2021. It may be in the back. Then they have 10 steps to correct coding. Then they have the guidelines. Is it in the back? It may be in the back. Is it in the back? Yep. It's in the back. It's in the appendixes. What appendix is it? Bear with me, people. The pharmacology list. Appendix D in the Optum 360 ICD-10-CM coding book, right? It says Appendix D, Z codes only as principal or first listed diagnoses. So they have them all in here. I'm trying to look at it and see what I can see off the top of my head that would be, yeah, Z01818 is here as a first listed principal, first listed diagnosis. So those pre-op encounters, if you have those, the patient is here for a pre-op, you know that Z code is going to go first. If that's the reason they're coming in, is for the pre-op. So the other one is at Z00.00 or the Z00.01. That is your annual physical for adults, right? So the Z00.00, I think that's the one with no symptoms. And then the 01 is the one with symptoms. Let me see. Did I recall that right? So 00.00 without abnormal findings, and then Z00.01 is with abnormal findings. And there's actually a note here that says use additional code to identify abnormal findings. So that's telling you what to do. Use an additional code. So knowing the difference between code also, use additional code, or code first is going to go a long way into helping you guys understand the sequencing. So yeah, I always get the Z01818 for pre-op visits when coding for family practice. I hate having to use it for the chest x-ray or EKG because I feel like it's almost an automatic denial. But that's like when they're checking them out, right? Just to make sure that they're good to go for whatever surgery they're going to have, right? Because that's what they have to report. Unless I'm reading you wrong. Am I reading you wrong? Hi, Brenda. I swear, every time I look at the clock, it's always like a little after 8. I'm like, so with Z01818, the pre-op exam, right? There's going to be different specialties. Some patients have to get clearance from other subspecialties or specialties before they can have surgery. Like if a cardiac patient needs an orthopedic surgery, right? They're still going to have that Z01818 because it's a pre-op exam. And that is why they're there, to be checked out, to make sure they get that clearance before they go and have their surgery. Because it's very important, especially if a patient is high risk, you know. So I don't think that would mean automatic denial. Everything needs to be supported. And if this is a pre-op visit, it's a pre-op visit. So again, getting familiar with your ICD-10-CM book is very key. Having good tools helps. And like I said, I like this one. People like different publishers, but this is the one that I trust. So that's my advice there on that one. Why did I pull this other article? I'm looking at it now and I don't know why I pulled it. I don't know why I pulled this article. So I really only like the two then. I don't know why I pulled this other one. There must have been something about it that caught my eye. But for sure those other two, the ones that I read to you guys, is what I really like. Oh, this is from the American College of Emergency Physicians. Why did I do that? I don't know. I don't know what I was thinking on this article. But I like the other two, so I'll let y'all know about those other two. But yes, so that is what I have to say on that, on sequencing. So hopefully it makes more sense. Always consider why the patient is there, what is being treated, and use those coding tips that are throughout your book. So that way you can have direction. Ashley says, all I have is my 2019 ICD-10-CM book. Is that okay to study? I read the guidelines for 2021 online. When are you planning on taking your test, Ashley? Because of course, since 2019, the ICD-10-CM has updated to the COVID codes. So there's also directions about COVID, and there's all those other things. So I know you're reading the current guidelines about it, but it would be good to know when you're planning on taking it. John Daniel, like I get a lot of Z13.9 for new patients who don't have any diagnoses. So I use the screening code for which the lab applies to. Oh, I already took the exam in 2020. Oh, okay. So you're just studying then. Yeah, that's fine. That's fine. I thought you were taking your test. Sorry. Okay. I see what you're saying, John Daniel. And yeah. Oh, you're welcome, King. Yeah, that's a sticky one though, John. Studying and refreshing my memory before I get a job. Have you gone to justcoding.com and signed up for the free subscription? Because it has those free coding quizzes that you can access when you sign up for your free subscription. ForTheRecordMagazine.com is another good resource. It's got a lot of good articles for coders on their website. And their subscription is free if you are a member of AHIMA or AAPC. Then you can subscribe to that magazine for free. Oh, you're welcome, Amy. Let's see what else. Then, of course, there's the Medicare Learning Network on CMS. CMS.gov has lots of free downloadable resources. A lot of insurance companies model themselves after CMS. So they are the the trailblazers. They are the trendsetters. They do everything. So I would check their website out for the Medicare Learning Network. And actually, you can just put it into Google, Medicare Learning Network, and it'll come right back up. And it's free, it's downloadable. It'll tell you everything about the surgery guidelines and about global surgeries and global service packages and things like that. And what does that mean? A lot of people ask about that. I try to explain it the best way I can, but that's what I can offer in there. Oh, they also need to make a code to describe a incisional site from an operation. Like a scar, like a keloid scar? Is that what you mean? Because if you're thinking of that, then that's just an educational thing with your providers, because sometimes like they'll have a keloid scar and it'll be painful, and the provider may have to do an injection for that. So it's just going to come up painful scar. Ashley, awesome. I'll check out the other sites out. No, like an active incision that's healing. And it's not closing? Is that what you mean? Like it's not closing? Like, the codes for post-acute, operational pain. Yeah, I got that. Yeah. So like things like that, like one that's not healing, not closing. If it's not healing, then there's a non-healing post-op wound code, I think. I can't think off the top of my head what the code might be, but I think it's something along those lines. It's a code that's like laceration, but it's not a laceration. Yeah, it's an incision. Yeah, there's a lot of codes that they update when they do update them. Like I think it was last year or year before last, they had all of those injury codes that got updated. And they added a bunch of new stuff, like more detail, so it's just like, okay, like that section needs more. Caitlin, I think I'll be dealing with those codes in wound care. Yes. That, or it'll be like ulcerations, like foot ulcers and things like that. So you're going to be looking at like a lot of like diabetic foot ulcers. So going over those guidelines for wound care would be really good. Reviewing something like that would be beneficial for you. I'm trying to think if there's any wound books that I know of. I know there's a lot of stuff in Coding Clinic. John Daniel, I don't know. I have a ton of ideas on ways they could describe the patient's healthcare journey. We paint pictures with ICD-10 CM codes, kind of like art. Yes, and that's why I say even reading the documentation is like an art, but we have to interpret it, and we have to interpret what we see. And the goal of provider documentation is to make sure that everybody gets the same conclusion. Because if you have different coders with different educational backgrounds, different experience levels, it is going to change how the codes get picked up too. And so you want to make sure that there's consistency in picking up the codes. So yeah. Any codes you think they need to make but don't have yet? And I always think of one, and then I can't think of it like right now. I'll give you a minute though. Yeah, everyone thinks it's gross, but I really think I'll enjoy it. When you don't think about when I don't see the pictures, I'm fascinated because they have done this to me before, my providers, right? So I'm looking at my notes, right? And I'm reading about what happened. This patient was in a accident, and then they had all of this trauma to their body, and I'm reading about it, and I'm fascinated, and all of a sudden, bam, I'll be scrolling down and I'll see a picture, and I'm like, ooh, I'm like, why did you do that? Why did you include a picture? But of course, sometimes they include pictures in the record because they need to show how it's closing or how either the wound is not healing or whatever the case may be. And so it's just like, why would you do that? No. So I'm fascinated until I have to see it. But that's just me. I can't imagine being back there though and actually seeing it. I probably would have hit the floor, but it's just me. That's funny. Any ideas or changes you think they should implement in ICD 11 that's not in 10? I'm on the spot. I am on the spot right now because I always think of these things. Like I always think of the codes that I would want, right? That you never see in the book, or it's weird. It's under some weird listed thing, The only thing I can think of that my podiatrists have told me that they would like to see is a code separately for plantar fasciitis and plantar fascial fibromatosis, because they say it's two different things, even though when you look in the book, it's defined under both as that, right? So under that one code, which is plantar fascial fibromatosis. And so that's, they wish that there was two different codes, even though according to us and the book, it means the same thing, or it falls under that code. Because just because it's worded a certain way does not necessarily translate to that is actually that. It also covers all this other stuff. So yeah. Caitlin, yeah, I had 2 family members that had pressure ulcers, so I have seen those. Hannah, ICD 11, when does that come out? 8 years from now. At least that's the last thing that I had read. It could be something else. But we got at least 8 years. Plantar fasciitis is a little confusing to me. Yeah, that's that M72.2. Yeah, it's that one. Oh, wait. Wow, okay. Yeah, when it comes to the new code set, just like they did with ICD-10, right? So with ICD-10, they kept delaying the start of ICD-10. They actually delayed it years. And then finally, they said, no, we need to get this and get it going. So they finally, voted it in, and they were all scared that we weren't going to be able to keep up. And there was a mass exodus of people too, because there was people who had been in ICD-9 for years, and they were not going to learn ICD-10, so they all retired. At least from my area, there was a lot of people that retired. And they just said, no, I'm not learning it. This one lady was like, I'm not learning that. I'm going to go ahead and retire. So she retired. She was like, no, I'm not doing it. To me, I was just like, okay, it's just a part of the phase of learning it. And that was all. To me, I wasn't like going to be backing down from it because, it's just learning something new. So, John Daniel, I think they would have added at least a laterality for it. And yeah, that's another thing too that they don't like, that there's no laterality. Hi, Christopher. He says, I used to hear about infected pacemaker pockets, protruding medical devices, and what defibrillator shocks felt like when I worked in that industry. I mean, just the defibrillator shock alone, because when you see those, like you see it on TV, right? That it like the whole body, like I can just imagine like how that would feel, John Daniel, instead of just an all-around code like M72.2. Yeah. Hannah, is it bad that I have only coded COVID maybe once or twice as a student? No, it's not bad. There's people that look up pica. That's that eating weird stuff. Yeah. You want the code for it, or are you telling me to look it up because you didn't know if I knew what it was? Is this in wound care? What, pica? Or are you talking about that infected pacemaker pockets? Because that would be, yeah, that would be like in wound care. But no, Hannah, there's veteran coders who haven't coded COVID patients. So, you know, yeah, it's not bad. It's not bad. The thing about coding for COVID is you have to know the rules. You have to know um, when to pick up the code and when to pick up the symptoms, when to pick up the exposure and that kind of thing. So that, yeah, you have to know those. But those rules are in the book. So, you know, you can read those. And then if something is related to, then you have to know about that as well. Dirt eating. Yes. Nah, I just thought it was funny. Oh, that's definitely interesting to me. I can't, like, I know there's people that have that, right? Because they did that show. I think it was on like TLC or something like that, where they were talking about those patients, but the people who had pica. And I don't know, like I think of their stomach, and I think of like their esophagus, and I think of like it's just it's going into your body, you know, and your body is like, and I don't know if some of these people have done it for so many years and so long that their body is just conditioned to it. But it's just like, man, you know, the body is a fascinating thing, you know, the things that it goes through. You know, I remember in the second grade a kid that would eat crayons and paste. Ugh. I mean, I've seen kids eat crayons or put like coins in their mouth, you know. I actually coded for a removal of coins. It was a surgery that I did when I was coding for surgeries. uh, this kid had swallowed 3 coins, and one of the coins was corroded. So this kid was sick. I mean, it was bad, you know, but yeah, I had to code out like removal of foreign object and that kind of thing. And yeah, it was a little hairy to read, but yeah. And then I've seen some other interesting cases where there's things, foreign body. Uh, I've done a lot of foreign body removals. What else did I do? Um, I've seen one that was a bead stuck up a kid's nose. I've coded for that. I've had some interesting ones, yeah, for sure. um, hey, Blue, what do you think about NASA having jobs for coders? I think that would be the most fascinating thing ever. You know, when I was, God, where was I? Was I in Miami? I may have been in Miami. I was either in Miami or no, I was in Miami. I think it was when I was in Miami. That astronaut, what is his name? He has the twin. He was there at that conference, and I thought that was fascinating. I've always been fascinated by NASA. Caitlin, yeah, they had the show where people ate brick and dirt and ashes, weird stuff. Yeah, COVID claims are all I bill for, Amy. Well, COVID tests and vaccines. Yeah. Yeah, we did a lot of that. I hated coding for the COVID clinic because we all had to do it. We used to. Now we're not doing it anymore because they closed the COVID clinic for us. So it's not, you know, that's not what we do because we were all rotating days, you know, and I'm just like, and it was like the same thing over and over again. I'm like, and there was like, you know, hundreds of these encounters, but you're just like, it's the same thing, you know, or at least the same set of codes, you know, that you have to select from and you're coding. So it just gets kind of boring. And I just couldn't wait to get back to the regular clinic stuff. So yeah, needless to say, when the COVID clinic closed, I was very happy. John Daniel, that made me excited for all the possibilities that are out there. Yeah, really. I bill them sometimes, but only commercial payers though. Though we only, for some reason, are only coding for the administration. 0011A. and 0012A. Bah. Yeah, not sure why we wouldn't bill out the actual vaccine. Because it's supposed to be free. And I think that's why. That's why. You're probably not doing that. Yeah. 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 Yeah, that's probably why. They just want to, I mean, right now, that's the way it is. So, I mean, that's why. Rules are a little different when you're doing things, and they were changing the rules a lot in the beginning when we were actively coding it, and so there was a lot of updates all the time. So that's the only thing. That's what's so good about the guidelines every year being updated, is because it's there, except when we got all the rules about COVID. This was the first time we had all gotten these rules in print. That new COVID code came out. It was unprecedented that they came out in the middle of the year. But then again, we were all in the middle of this pandemic. So, it's just what happens when when this stuff happens. And as fast as they created that code, that is, again, unprecedented, John Daniel, I remember in college we had this poster of an old lady ran over by a reindeer, and it said, "There's a code for that." Caitlin, yeah, I was skeptical, but after I get through this, I am going to get my vaccine. My teacher always laughed at that. That was mean. But yes, Caitlin, I mean, there's a huge debate about it all the time. I mean, people have different ideas, and it's natural to be afraid. You know, it's just one of those things. People believe things, and then there was so much information coming out all at one time. It's understandable to be skeptical, right? Because even I was just like skeptical myself. I did get it, but it's just one of those things that we're all going through it. Just like the whole world. The whole world is just going through it. But what are you gonna do? Amy says only the admin code gets paid. John Daniel, you ever code something and feel bad, like you're almost insulting someone because of the code that's selected? Yes. Some of those just like, really, I gotta code that, but yeah, there's times when I felt like that, like, if really, yeah. I've used a few of those codes before. We bill both, but the vaccine gets paid a penny. Yep, because they have to. I guess they have to put something in there, right? So they have to do a penny. Caitlin, Josh is definitely getting more excited about the things I will see in this career field. John Daniel, I feel that way sometimes. I feel like I'm indirectly insulting someone by the way that they look when I used R46.1 bizarre personal appearance. Christopher, I had COVID several months ago, and my doctor says I should have some immunity already. Well, that's good, and thank goodness that you're good now. John Daniel, I'm like, what would a person have to look like for her to say that a person was bizarre looking? Or like when they say that the patient was disheveled, I always kind of giggle because the word disheveled is funny to me. I don't know why. Don't ask me why it's funny. It's just a funny word. But yeah, that's But hopefully you continue to feel well, Christopher. I'm glad everything's okay for you. It's just, we're all coming out of this COVID time, so, disheveled. I don't even know what that is. It's like somebody who looks sloppy, disheveled, or like their hair is not combed, that kind of thing. That's disheveled. Yes. No. Brenda. I'm not talking about E&M tonight, but I'm talking about sequencing. But E&M maybe next week. Nobody said anything. No one said about wanting, because I told you guys like Monday or Tuesday if you wanted E&M to let me know, and no one said anything. So okay, so that's why I went ahead and picked sequencing. So hopefully this one was good about sequencing. But I will do another one on E&M. John Daniel, disheveled, like something with a shovel. No, not disheveled, disheveled. Okay, I got you. Disheveled. There you go. Thank you, Christopher. We're talking about people's no, we are not talking about people's shovels. Disheveled. Disheveled. Okay, let's get the official definition of disheveled. Okay. Define disheveled. Of a person's hair, clothes, or appearance untidy, disordered. That's what that means. Your providers don't use that word. Amy, could you again please provide us with the 2 coding websites that we could reference? Justcoding.com and cms.gov. For the Record Magazine.com. John Daniel, I like HCC enough. I like sequencing. Do it enough and you'll be a HCC hero or a risk adjustment pro. I like to think that I have those skills already as a coder, you know. And so like when I see like the specialties, like the risk adjustment and all this stuff, I think, you know, a coder can do that, you know, just a regular coder, you know, somebody who has their certification, because that's what we do, you know. Even on the inpatient side, if you're working inpatient and you have to think of the principal diagnosis, that principal diagnosis has to be correct, because as I have learned, if you get that MSDRG wrong, oh yeah, it can cost the facility money. And so that's why it's so important. And so then when I look at these job postings for like risk adjustment, and they're not even asking for the person to be certified. They say all that the person needs is a high school diploma or a GED. And I'm like, but they don't have technical training. How can you get somebody who doesn't have technical training to look at diagnoses and expect to know what sequence to put them in? You know, so just like, but I will tell you one thing. I did learn something new about medical auditor. So I saw that thing on AAPC, right? Because people are asking me about that. All of a sudden, it's popular. They want to be a certified medical auditor, and so I'm like, certified professional medical auditor or something like that. And I'm like, I'm thinking auditor like audit, like you're auditing other coders and things like that. No, it's not that. It's auditing and abstracting and all this stuff. Basically coding. So it's just like, okay, coders do this. Everything that I saw on this list for this certified professional medical auditor is stuff that coders do. Yes, it's more regulation probably, but it's stuff that you should already know as a coder. I mean, like about the regulations and things like that, and how to explain this stuff. And, you know, abstracting and auditing. Abstracting meaning that you are the one that's selecting the codes. You're the one pulling the codes from the documentation, you know, or auditing and the fact that some of these providers select their own codes. And as you're going through and you're coding, you're either correcting those codes or you're letting them go through because they're correct, selected correctly. So it really all depends, you know, on your facility. Some facilities have that and other facilities have you as doing the abstracting. So it's just like, it's just a play on words. So I'm like, So there was a lady that was asking, you know, should I be a coder first before being a medical auditor? And I thought she meant like medical auditor and something else, like how they can go in and they can like audit for like medications and things like that. That's what I was thinking that she meant. And then when I saw that today, I was like, that's what that lady meant. I was like, oops. So guys, when you're asking me about these other credentials, I'm thinking to myself, like, where are all these other credentials coming from? That's what I want to know. But I didn't know about that one until I looked today, because I looked on the AAPC website today and I was like, that's what she meant. So, my bad. Caitlin says, that sounds funny to me, like when I found out cheeks in medical term was buccal. Yep. K Blue says, yes, Caitlin, it's such a random word for cheek. It is. It totally is. John Daniel, yeah, there are so many dumb payment methodologies that don't even want to deal with it. That's why I want to be in research or something like Cancer Registrar. You're welcome, Amy. John Daniel, yeah, CPMA will be a no-go for me. The only auditing credential I'll get is the AHIMA version. The CPMA is way, way, way too broad, while AHIMA actually applies job titles and roles. Caitlin says that, yeah, that's the crazy thing about the CCA, the DRGs, and the MSDRGs. Yep. They have to know inpatient and outpatient. John Daniel, I think the word hammer toes is actually funny for some reason, and giggle whenever I see it on the encounter. Yes, hammer toes. What is it? Bunionette. When I see bunion and bunionette, I think that's funny too. I always think bunionette is funny. What else do I think is funny? There's a bunch of stuff that I see in these notes that it's just like, I giggle. Some of the stuff, like, really, or like when the patient wants to have their pins taken out and it's like 2 weeks and it's too early to have their pins taken out, and they'll demand to have their pins taken out because it's uncomfortable. While understandable, you still need to let yourself heal. There are certain things that you need to do to let your body heal. But that's funny. Yeah, hammer toes is funny. It's like, I bet that person who has hammer toes don't wear any sandals, and that must be embarrassing. Yeah. And I mean, especially like when you're working podiatry, like, so for some people it's just like, or they have the calluses on their toes, on their feet. That's the other thing too. Some of those can get quite painful, or like ingrown toenails. I feel so bad. The ones that I really feel bad for is like the diabetic patients, because I have to be really careful with those, and it's just like, I feel terrible for them. That I feel bad about. Yeah. But some of these other things, like when I see like some of these injury codes, when I see that they fell off, they fell down the stairs, or they tripped off the curb, or one, and I know I shouldn't laugh, but the thought of it was funny, because the provider said that the patient owns a very large dog, and the patient is petite, and the dog pulled the patient, and the patient was dragged. So I felt bad, because all I could think of was that poor woman just being dragged by this big dog, but she's okay. She just was roughed up a little bit, but it's just poor thing. But these dogs, you can't, I mean, like, they're just so big, you can't expect to control a 70-pound, 80-pound dog, Maximus the Clone, I'm surprised at the pay differences from state to state. For example, North Dakota is about $57,000 a year, while Florida is about $30,000 a year. John Daniel, yeah, I was a PCT for a time to get a taste for healthcare as my entry-level job, and I remember a guy with diabetes mellitus and was gonna have his leg amputated, but he had to wait a few days. Oh my goodness. Christopher, twiddler syndrome is when a patient fiddles with their pacemaker or defibrillator and displaces it. I didn't know that. Twiddler syndrome, that's funny. But bad. But funny. John Daniel, for the doc to determine where to amputate the leg, and the guy was in crazy pain. Well, because they have below the knee amputation and they have above the knee amputation. So below the knee, there's a little bit more control, and I think the recovery time is less because they still have that hinge of the knee, right? But if they have it above the knee, that's a whole nother rehab. You have to learn to walk again. If you have that, you do have to learn to walk with below the knee amputation because you still have the hinge, but you have to work with your gait. But if you have an above the knee, again, it's a different anatomically, it's going to feel different, and they're going to have to learn how to walk with the prosthetic. So it's a lot different. It's not just when they do something like that, they have to think very seriously, because once it gets to where it's either below the knee or above the knee, that above the knee, you can only go so much, and then that's it. Then you got issues. But if you go below the knee, that patient has to be in a place where they're going to be able to heal, number one. And it's not going to be something where if they have like an infection, it can go up and then they have to take off more of that bone. It's about preserving as much of the bone as they possibly can, even when they're doing something like that. So a lot of consideration has to go into that kind of thing. A lot. And Kayla says, I love that word, Twiddler syndrome. I think that's funny too. Oh, hey, you can answer this, Blue. You know the codes for stumps, like the complications of stumps. Not off the top of my head, but yes, yeah. Like infection of the right lower stump, amputation location. Does that code make the provider liable? I don't know. Because sometimes it's not even the provider's fault. I mean, it depends on what caused the infection. I mean, the provider may have done everything right, but the patient may have gone home and not taken care of themselves. I don't see how the provider could be liable for that. You like complications after surgery. It depends on how it's documented. If it's documented well, I have no issues. When it's not documented clearly, then I have a problem, because it's just like, okay, we're missing detail here. What's going on? And if they don't really want to say, because they're like, they don't know, or they're confused, or like you say, are they liable? It all depends. I mean, it's, just because a patient gets an infection after surgery does not necessarily mean that the provider is at fault. Doesn't necessarily mean the patient is at fault. The patient could be having a reaction to the implants, if there's implants. There's always that, and that's nobody's fault. Sometimes that stuff just happens. Because I was ready, and it was in the section, or was in the T section, and was making me think that any codes from this section makes the provider who did the surgery operation liable. Was a little confused about that. It doesn't, just because you're using those codes does not necessarily make the provider like it's their fault. Everything has to be investigated and looked at, so it's not just because you selected it. Hannah, how do you deal with eye fatigue from working, looking at screens and codes all day? So sometimes my body will tell me if I'm looking at the screen too long, because my eye will start to twitch. And so when I know my eye starts twitching, I have to close my eyes and I have to kind of like just take a break. But for the most part, I try to make sure that I look away. If you ever notice when I'm talking on camera, you'll see me look off or look this way or that way. It's because I've gotten into the habit of not staring at something for so long. But that's what causes eye fatigue, is when you start staring, and it's just something that happens. It's not something that you think of. It's something that just comes like instinctually, that you'll just be like so into whatever you're doing. So it's important to get into that habit of starting to move your eyes around and get used to that. You also have to move your head around, and you have to be able to move around in your chair, because when you do that, then you're not going to be so stiff when you get up, or you're not going to be like where your eyes are tired, so it depends on how you're taking care of yourself and your body. And this is why I keep telling people, you have to take care of your body, and you have to stay hydrated, and you have to get some kind of movement, because we do sit all day long. Like I said, I think a couple days ago, I'm starting to get back into walking again. And I remember now why this was so important, because when you walk and you move around, it does help to clear your mind, and you're able to focus. So that also helps. It'll give you time to rest from staring at the screen, and you've done something else, and then you'll be able to do all that stuff. Some people use that blue light protector to keep from getting so much blue light. Some people use glasses to protect their eyes as well. So it really all depends on you. But I think, as long as you're keeping yourself, with your eyes moving around, that you'll be all right. It's when you start to stare at stuff, or you're using bad lighting to be able to read, that also does affect you. If you need to wear glasses, you have to wear glasses. Don't be vain to not wear glasses, because you're only hurting yourself in those situations. John Daniel, I'm confusing you and myself to get my point across. You got any plans this weekend? Mercedes! Oh my gosh, where have you been? As far as my plans this weekend, I have a couple of things I have to do, but I will be finishing my CDI program probably this weekend. I really want to, because it's almost getting time. So that is what I'm going to be doing. So a lot of fun stuff. Just so much fun. It is so good to see you, Mercedes. I haven't seen you in forever, lady. Amy says blue light glasses are helping me. See? Hannah, I have blue light glasses and blue light or easy mode eye mode on my computer. See, yeah, you can always do that. John Daniel, oh, hey, Blue. I messaged some of my providers and pitched the idea if they'd like to receive a monthly email on changes, updates, and tips on coding and clinical documentation, and said yes. Yeah, see? That's good. Hannah, still mentally drained and eyes are so tired. And especially when you're reading all day, it does drain you. And you do feel tired. It just feels just as exhausting as if you have been out running around all day long. Because trust me, there are times when I have been reading all day, and then by the time I come in, boom, the first thing I do is hit the couch and fall right to sleep. If I didn't have you guys to work with every day of the week lately, trust me, I would have overslept. I would have slept all the way through had I let myself sleep as soon as I got it off work. But yeah, it does happen. But there's too much for me to do right now, between the channels and working on my schoolwork at home. There's just too much for me to do to be able to do something like that, which is why the weekends I really like to sleep. But not this weekend. I've got stuff to do. John Daniel, use the night light at 80% tint and your eyes will not get those headaches. That's what I use. And never had a headache since if you're using Windows 10. Caitlin says, I will have to remember when I start work. I have blue light glasses and reading glasses. John Daniel, hey Blue, name a movie I should watch this weekend because I have nothing to do. Mad Money. So I've been because I have Amazon Prime, and clearly we are in the end part of this night, so we are not talking about study hall anymore. But I've been watching Amazon Prime, and they have like free movies on there. So I watched Mad Money. I haven't watched Mad Money in a long time. But it's so, I love that movie. I love Diane Keaton. She's freaking hilarious. And then you have Queen Latifah on there. Hysterical. But yes, I love that movie. So I watched that. But I would suggest it. But it might be too girly for you. So you could always watch Red. Red is a good movie. That has Bruce Willis, and hello, it's Bruce Willis. So Mad Money. Caitlin, I would say the new Conjuring, but I love horror movies. I can't with horror movies. What is that one? It's that one with, she was in Save the Last Dance. I forget that movie, but The Omen. No. I get nightmares thinking about that movie, but yes, The Omen. That is the scariest movie. No. Any of these other new movies that are coming out, that you see the commercials for them and stuff like that, the scary ones, no. I can't. Because then I'm scared for weeks, and I can't like go anywhere without jumping because I think of like something's jumping out, or no. I can't. The Conjuring. John Daniel, love this series. Chick flick. Christopher. I also like The Nun. Caitlin, such a good series of movies. And then they even got a documentary out on a couple that did the cases. John Daniel, where you have that demon dresses like a nun and haunts the church in Romania. Oh, no. No. That's pretty crazy. Discovery Plus. I still have nightmares from The Ring, and I watched that almost 8 years ago. No, I believe you. No, I can't. I personally like things like Dateline, like true crime. You know what I mean? Like stories like that. Like I like true crime. Not that I like for that to happen, but the storytelling part of it, that is okay for me. But when it comes to like the movies, it's just like so sensational. No. I can't. Like I said, The Omen is the scariest one, and that's it. No. If I feel like being scared, I'll watch that. But I did get Amityville horror movie or whatever. I didn't watch it. I have it, but I didn't watch it because I was too afraid. Because I said, okay, on like Halloween time, I'll watch this so I can be like in the spirit. And I look at it, I'm like, no, I don't want to watch it. I just do that. Yeah. I love the paranormal stuff. And yes, I love watching Joe Canada. John Daniel, hey Blue, you remember last week when you told us how you loved watching Magic Mike on repeat because you wanted to learn the new dance moves? Oh, you're funny. I didn't say that. But I did like Magic Mike. Magic Mike was pretty good. I liked watching him. I mean, the first one was good. The second one was okay, But I couldn't get into the second one. The second one I couldn't get into, but the first one, first one was good. Caitlin, that was the one of the cases that the couple of the Conjuring couple did. Ugh, I can't with the Conjuring. No, it's too scary. It's too scary for me. It's too scary for me, y'all. No, I can't. But I think it's supposed to rain a lot anyway this weekend, but I will be watching something funny, pretty sure, if I'm not going to be reading. So, with that, y'all, I'm going to go ahead and close this up. I hope this was helpful. And yes, I know that with sequencing, it does get a little iffy. You just have to keep working with it. That's all you got to do. Just keep working with it. Because eventually it'll make sense, John Daniel, the Annabelle movies link to the Conjuring movies too. It's pretty cool. Yep, same universe. Thank you. All right, guys. Insidious, the first, is by far, for me, the scariest. And the demon with the hands when the movie sounds like broken. You need to watch funny movies, Johnny. And you just watch something funny, okay? Caitlin, signs is the one that freaks me out. Okay, yeah, the crop circles. No. I can't do crop circles because I watched, what was it I was watching? It may have been the Discovery Channel. They were doing a thing about crop circles, and I fell asleep watching it, right? So in my dream, I start dreaming about crop circles, and then I start seeing aliens, and I'm like, oh, no. So I get up really fast. The TV is still on. So I'm like, no, I'm changing this. All right, y'all, and I will see y'all. Have a great weekend. Oh, and I'll be back the weekend for Christmas in July continued. So I will see y'all then, but have a good weekend, y'all. Bye.